And now we invite Dr. Amit Gupta to present his talk on corneal biomechanics. Dr. Amit.
Thank you, sir. Well, when we look at corneal biomechanics, this is a branch of science that deals with deformation and equilibrium of corneal tissue under application of any force. And the cornea is considered as a viscoelastic material. Now, what is this viscoelastic material? So, elasticity, if you look at it, is the capability of a strained body to recover its size and shape after deformation. And materials with a higher modulus of elasticity are stiff, and with a lower modulus of elasticity are weak. And this is not a time dependent component. So in the cornea, essentially the collagen in the Bowman's layer and stroma, which is 80% of the dry weight of the cornea, are major contributors to the corneal elasticity. On the other hand, viscosity is the resistance of the material to flow or a permanent resistance to a permanent deformation, and this is a time dependent component. And this viscous behavior comes from the ground substance mostly formed by proteoglycans and keratocytes and fibroblasts, and corneal epithelium, which accounts for 10% of the corneal thickness. So this is the viscoelastic behavior of the cornea, just like a memory foam. You press it and then you release it, it slowly comes back to its normal shape. And this is what is utilized to study the corneal biomechanics. Now, why are corneal biomechanics important? They play an extremely important role in the accurate assessment of IOP, in identifying risk factors for glaucoma, medical treatment of glaucoma, identifying the patients at risk of ectasia, and following up patients of keratoconus, and measuring the effect of cross-linking, and improve predictive outcomes, refractive outcomes in patients, and many other indications. I'm sure they're coming forth even now. Now, there are several technologies which have been used, some very complicated technologies also which have been used, but ocular response analyzer was one of the first one, and now we have the Corvis ST, which is a Scheimpflug imaging combined with the non-contact tonometry. Other things are ultrasonographic elastography and high frequency ultrasonographic analysis of corneal changes. The Brillouin optical microscopy is a new fancy term on the block, and other techniques including dynamic corneal imaging and OCT based and elastographies. So if you look at the ocular response analyzer, this was first launched in 2005. And what it does is, it's a fully automated alignment system. So once the patient is positioned, it positions itself so that an air tube is in precise position relative to the apex of the cornea. And once it is aligned, it directs a rapid 25 millisecond air pulse to indent the cornea. This corneal deformation is then recorded via a device and a system, and the ORA then acquires the corneal biomechanical data by quantifying this differential inward and outward corneal response to an air pulse over a span of approximately 20 milliseconds. I'll just spend a little time on explaining this because that's the crux of how we measure it. The cornea is appanated roughly 3 millimeters. What happens is there is an air tube which fires the pressure onto the cornea, and only when the cornea is appanated is the signal strength of the light, this infrared light, is going to be maximum. Right now it is spreading, so once it is appanated, the signal strength goes up, and because the cornea is moving down further, and then the air jet decreases in intensity, and it is coming back again, and then the signal strength is again going to come maximum, and then it's going back to its normal apnea. So this is the crux. This is the crux of the graph which we get to study the corneal biomechanics. And so this shows the in signal peak again, so that the light is at the maximum, and then again the out signal peak, and the light is again once the cornea is depressed, and then again when it's coming up, again appanated, and then goes back to the normal position. So this corresponds to P1 and P2, which are the air pressures which are corresponding to the two applanation states of the cornea. And like I said, the P1 is the first applanation when the air jet flattens the cornea as the cornea bends inward, and the P2 is the second applanation when the cornea is recovering after going beyond the applanation point, and then it's recovering back again. So these are the things which we use to derive the biomechanical parameters. Most important, of course, is the corneal hysteresis. So corneal hysteresis is a measure of the viscous dampening of the cornea, and it is defined by the difference of P1 versus P2. I mean, we would expect P1 and P2 to be same. It's not the same just because of the viscous dampening effect of the cornea. And this is a very important parameter to study the biomechanical properties of the cornea. The second important term is the corneal resistance factor, or CRF, and this is an indicator of the total overall resistance of the cornea. And again, this is a complex equation to express that. Important to remember is that it is significantly correlated with the central corneal thickness and also the Goldmann applanation tonometry. So this could be mainly related to the elastic properties of the cornea. CRF, measure of elastic properties, and hysteresis, measure of the viscous properties of the cornea. Then the Goldmann correlated IOP. This is IOP-G, so this is P1 plus P2 divided by 2. So the average of the two applanation pressures is the Goldmann applanation pressure. And then the corneal compensated IOP. This is, I think, extremely important. It is less affected by the corneal properties than the IOP obtained with other tonometers. So there's a formula for this, is P1 minus 0.43 into P2, and this gives us this data. So for example, in the last presentation we were seeing the pressure-induced stromal keratitis, which we were seeing in a LASIK patient. Many times a Goldmann NCT will give you a normal reading, and when you go ahead with this, it will show you the IOPs in 40s and 50s. There are other factors like a cornea constant factor, and this is again, it is an IOP independent biomechanical property that increases with thicker corneal. So there are like many, almost 37 parameters are there in the aura, and there's a computerized way to study it and then reflect it on the screen of the patients. Important to remember, what are the factors affecting the corneal biomechanics? Age, does it affect the biomechanics of the cornea? So some studies have shown that corneal hysteresis significantly decreases with age because there's an increased corneal stiffness. Again, conflicting data does exist. Central corneal thickness. What happens if a cornea is thick or thin in a patient? So many studies have reported a positive correlation between corneal thickness, of course, and hysteresis, and also with the corneal resistance factors. And also, it's important to remember that there may be a circadian rhythm of the corneal thickness, so that the biomechanical properties may also fluctuate. What about myopes? Studies have shown that myopic eyes are weaker eyes. So there is a negative correlation between hysteresis and myopia, indicating that the mechanical strength of the anterior segment of the eye is somehow compromised in high myopia. Intraocular pressure, cornea with high hysteresis and high CRF. So what does it mean? High hysteresis and CRF means when we are doing Goldmann applanation tonometry, there's more resistance to applanation when we do Goldmann. So that means that the IOP, which are values which are recorded, may be higher actually than the actual values. And the reverse goes true in eyes with lower hysteresis and a lower CRF. And so IOP-CC may provide a more realistic measure of intraocular pressure in these series. So if we have patients where we are seeing that the hysteresis and CRF is abnormal, I think we should consider the IOP-CC as well. So if we look at conditions which are affecting the corneal biomechanics, look at ocular diseases, how they affect. Glaucoma, I think it's a very relevant application in glaucoma patients. Why? Simply, what is ocular hypertension and what is normal tension glaucoma, and all these things may actually be differentiated if we look at the hysteresis and corneal resistance factor more closely in these patients. But I will not go into detail in this. Look at keratoconus. We know that there's a significantly weaker stress and strain response in keratoconic eyes compared to normal eyes. And corneal hysteresis and CRF are significantly lower in keratoconic eyes with a stronger decrease as the severity of keratoconus increases. And it has also been shown to correlate with the optical aberrations in the eye. So just a representative, so we can see how the signal amplitude has gone down along with the CH and the CRF in these patients. What about refractive surgical treatments? Again, we show that just the act of making a flap is the more important factor when it comes to decreasing the hysteresis and CRF. It's even a more important factor than the depth of the ablation in these patients. Of course, as PRK would cause less changes in hysteresis and CRF compared to LASIK and SMILE. And LASIK and SMILE, there's no statistically significant difference between the two when we see. So it is recommended that especially if you have a patient less than 8 hysteresis reading, we should not proceed with refractive surgery in these patients. That's very important. So this is one of the things I use in patients who are borderline. Do the biomechanics, and if you find that there is something abnormal, don't proceed with the refractive surgery. Just the last one, Oculus, this is the Corvis, which is a corneal visualization Scheimpflug technology, and this is the new instrument which is available. So it uses an ultra high speed Scheimpflug technology, more than 4,000 frames per second, tonometer, pachymetry is there, non-contact tonometer, symmetrically metered air pulse is there, and captures 140 images over 31 milliseconds. So this is a timer which is there, and now you can see what happens to the cornea. Once the air puff is fired, so the cornea is being, and we can see the oscillations as well. And these are recorded, and there are plenty of parameters which are given. So what happens in ectatic corneas? There may be a significant decrease in the deformation amplitude, significant increase in oscillation of the cornea after the air pulse. Both effects can be seen simultaneously with a high-speed camera. Just to conclude, the application of corneal biomechanics, it provides a new dimension in diagnosing as well as prognosticating various corneal disorders as well as glaucoma. And several new advancements are in the offing which will help these patients. So many new techniques are coming up, and more data is needed for complete application of this science into daily practice. Thank you very much.
Thank you, Dr. Amit.